My name's Paul Ursell. I'm an ophthalmologist in London. Mainly work as an NHS consultant in Epsom and St Helens in South London, and I also do private work at Surrey and in Wimbledon in South London. So my work is mainly cataract. I'm the director of our cataract unit in our hospital. We do about 2,500 cataracts a year in the NHS, and then I do a lot of cataract surgery in private practice as well. All cases are challenging cases, but some are more challenging than others. It depends on the type of person you're dealing with. It depends on the patient's eye and their behaviour. Some people are very nervous and they're very scared, and you have to work them through that. It can be quite challenging as a surgeon, so you have to use a lot of personal skills with patients to make sure that they enjoy the surgery as much as possible without finding it too frightening. So that can be very challenging. There are surgical issues with how you do the case, so particularly dense cataracts or small pupils. Small pupils are something that we see a lot of where I work, and we primarily use pupil expanders such as the Moluccan ring for our patients with small pupils. And I find that probably in about 10% of cases we're using it now, maybe a bit less, maybe a bit more depending on the time, because not every patient dilates well with drops, or they have other pathologies in the anterior chamber. It means that they have a small pupil. And once you become comfortable with using Moluccan rings, you find yourself using them more and more because you think, well, I don't need to be in a position where it's stressful. I don't need to be in a position where I'm worried about the outcome of the case. If I have the Moluccan ring in, pretty much the case standardizes itself, and then I can do my routine normal case as I would. So you find that the more you do, the more you do. I think you have to be a good surgeon, and there's no getting away. Some surgeons are simply better than others. We can look at all sorts of parameters to assess that. I have got 11 consultants who work with me in our department. We've got lots of junior doctors, and you can see a variation in skills. You don't see much in the variation in outcomes, so even though some surgeons take longer than others to do surgery, the outcomes are the same afterwards. Instrumentation is very important. Some surgeons are happier with different types of instrumentation than others, so I think it's definitely a split between the two. If you have good instrumentation, you can do it operation. I go out and do volunteering, and I go out to the third world, and we get given all sorts of different types of instruments in Cambodia, in Burma, places like that. And you have to be a competent surgeon to use the instrumentation. And you definitely see how, if the instrumentation is second-hand or has been re-sterilized when it shouldn't have been, it's much more challenging as a surgeon than if it's good instrumentation. So you can definitely see the effect of that. I really am very keen on Moluccan rings. I think that I know Boris Moluccan, and I think that the device has revolutionized, the wrong word, but it's certainly made cataract surgery much more reliable, much easier, much more reproducible, which is what we want. We want to do the same case over and over again. I find that with the Moluccan rings, it just reduces my stress level. I can put one of the rings in, I know how it works, I can take it out, and I get a very reproducible, familiar environment for me to do my surgery. So I find that incredibly helpful. They're very simple to use, and I haven't looked back since starting using them. Weak zonules are probably the most stressful thing that I have to deal with as a cataract surgeon, unless they've had major anterior segment trauma. But weak zonules are the one thing that's going to concern you. There are various strategies. First of all, you want to try to preempt any issues you can before the surgery. So you want to make sure your patient is as relaxed as possible, you have good anesthesia, you have good draping, you have a good positioning of the patient, so that many of the things that could go take you wrong with the surgery, you try to preempt before things happen. It's a process I call normalization. You make the operation normal. You make it normal. Then I would basically ensure that I have as good pupil dilation, so I definitely use a Moluccan ring. For doing the capsulorhexis, I would use a cystotome. My normal technique is to use a rhexis forceps, but I would start the capsulorhexis with a cystotome simply because I don't want to put any pressure on the zonules. I make a large capsulorhexis, bigger than I would normally make. You really don't want to have any problems with the surgery. And copious hydrodissection, so ensure that the nucleus is completely free before you do any rotation to avoid putting any stress onto the zonules. We are blessed as a community. We do the most unbelievable thing. You make people see. I have medical students who come with us, and I say, well, unless you're very lucky, you'll have to go, very unlucky, you'll have to go off and do something else because you're not going to be lucky enough to become an eye surgeon. It's a fantastic job, and it's almost like It's like the Old Testament, you lay on hands, like Gandalf, you lay on hands and people see, and it's the most rewarding thing you could do. I mean, I say to my friends and my trainees, if someone else would pay my children's education and my mortgage, I'd do it for free.